We've got a what? We've got a clinical case. Let's go. 62-year-old lady, 62, presents for her annual physical examination. She has a history of well-controlled hypertension, hyperlipidemia, and a strong family history of coronary artery disease. Her father had a myocardial infarction at the 55. Okay? She's a non-smoker. Her body mass index is 28. And she has no personal history of cardiovascular events, diabetes, no history of CVD events, diabetes, or active bleeding. She asks if she should start taking daily low aspirin to prevent a heart attack. Good question. As her friend does, yes. Her calculated 10-year atherosclerotic cardiovascular disease risk is 8.5. So which of the following is the most appropriate recommendation regarding initiating aspirin therapy for primary prevention? Give me options. So, advise her to start aspirin 81 milligram. 81 is a United States dosage. 61 milligram day immediately due to her elevated atherosclerotic cardiovascular disease risk and strong family history. Option B, recommended against initiating aspirin therapy at this time, as the potential bleeding risk likely outweighed the cardiovascular benefits for primary prevention in her case. I suppose this is correct. Next, suggests she try aspirin 81 every other day to minimize bleeding risk while still providing some cardiovascular protection, and prescribe aspirin 325 daily to ensure robust primary prevention given her risk factors. My beloveds, correct answer is option B. So the patient is being considered for aspirin in primary prevention, preventing as the first cardiovascular event, while she has risk factors, hypertension, hyperlipidemia, family history, elevated atherosclerotic cardiovascular disease risk at 8.5%. Current guidelines, such as current guidelines, right? Generally recommend against route initiation of aspirin from primary prevention in adults aged 60 plus, and for those aged 40 to 59 years only when the 10-year atherosclerotic cardiovascular disease risk is more than 10%, and the patient has a lower bleeding risk. So her 10-year atherosclerotic cardiovascular disease, we've got 8.5, which is below the 10, of course, threshold where aspirin might be considered, which is below, which might be considered, in younger individuals 40-59, age 40-59. For individuals 60 and older, 60 plus, Our Lady 62, the increased risk of major bleeding, especially in intracranial hemorrhage and major GI bleeding, generally outweighs the modest cardiovascular benefits in primary prevention.